And thanks, Wes Onland. He's a colleague of mine. We both trained in the academic center in Amsterdam in the Netherlands. And Wes just told me it was 2008. I thought it was earlier, but I remember it as being earlier, maybe 2005. So we both hang around in the NICU and did a couple of projects together and particularly worked a lot together. And Wes has gone from just his interest of working particularly on ventilation, which was a high topic in the academic medical center, to, now did his own trial looking at hydrocortisone in preventing BPD and other BPD and dexamethasone related work, particularly in overviews and systematic reviews of these trials. So Wes, we're really glad to have you here. The floor is yours.
Thank you very much, Kurt, for this kind introduction. Let me share my screen again. There we are. All right. Well, thank you very much for the invitation. First of all, I would like to thank the organizing committee. But I wanted to start that I have no financial relationship, but I am the co-PI of the one of the trials I'm going to present. So bear that in mind. First, I wanted to show that where do I come from? Well, from the other side of the world, and I had to draw a big arrow to show you where the tiny dot is. That's the Netherlands. That's where I live and work, and where Kurt is coming from. So, and the Netherlands, I don't know if you ever heard of it because it's so small. But what we are doing in the Netherlands is constantly fighting against water. We have a lot of water. It's below the sea level. So what we're doing is building. If we do not build any dikes, then this is what the Netherlands would look like. Approximately 20% of our country would be left if we do not have any dikes. What do you know the Netherlands from? Well, I think from the windmills, from the ice skating, especially now in the Olympics. The Dutch are very good in skating. But what we know from the Netherlands is it's flat. We do not have any hills. That's something all tourists are surprised about, that it's completely flat. And this is where I live and work, and that's Amsterdam, the capital of the Netherlands. What about the NICUs in the Netherlands? Well, we had 10 NICUs. We have approximately 165 births per year. And in those 10 NICUs, we admit about 1,000 infants below 30 weeks. Recently, we have become 9 NICUs, because in the Amsterdam, there were originally 2 NICUs, but we have merged, and now there's one big NICU in Amsterdam. It's a complicated process, I can tell you. This is what the AIMS looks like about 50 years ago, with a lot of cows before it. That's the AMC. And my personal history is that I began my residency in the NICU in 2002. And at that time, the neonatologist, among which Kurt de Waal, was wondering, what should we do with dexamethasone? Should we lower the dose? And since then, like Kurt said, I got definitely interested in the steroid use in neonatology, wrote a couple of systematic reviews, and was the co-PI to stop BPD trial. But it all started, and that's what I pointed out, in 2005 with this publication, one of my first publications with Kurt de Waal. So it's like circle of life. We're back at the beginning. For the next 40-45 minutes, I'm going to tell you about steroids and focus on the randomized control trials that have been conducted for the past 5 years. First, a few words about why do we use steroids? What is the evidence from the randomized control trials before 2016? Because we have been investigating dexamethasone and hydrocortisone for quite some time now. What do the guidelines say to us, and what are the consequences of those statements of the guidelines? And then finally, the focus on hydrocortisone trials which have been conducted and published after 2016, and then conclusions and future perspective. So first, why do we use steroids? Well, because BPD, we want to prevent BPD. It's a very common complication of preterm birth, and it has both neurodevelopmental and pulmonary long-time, life-lasting consequences. And this is a picture showing that BPD is a complicated multifactorial disease. But one of the main reasons why we use steroids is because there's an inflammation part in the development of BPD. And with corticosteroids, we are hoping to temper the inflammatory response causing BPD. And this is what we hope to accomplish with corticosteroids. On the right side, you see that with corticosteroids, we try to reduce ventilation time. And by reducing ventilation time, we try to reduce BPD incidence. As we know that BPD is associated with neurodevelopmental impairment, by reducing BPD, we try to reduce the central nerve system damage. What we also know is that corticosteroids have a direct toxic effect on the central nerve system. And of course, that causes an increase of central nerve damage. So that's what corticosteroids always should be about the balance of beneficial effects and adverse negative neurodevelopmental effects. What do we know from the randomized controlled trials before 2016? Well, mainly that they were from dexamethasone trials. And roughly you can divide them into two groups. One investigating an early initiated therapy before 7 days of postnatal age, and a second of after 7 days of postnatal age. And first, the early dexamethasone placebo-controlled trials, and I'm going to show you a lot of slides with this figure of meta-analysis, where you show that there's an outcome, there's a number of participants in that meta-analysis, the effect estimate, and when it's above 1.0, it's a beneficial effect, in other words, it's an adverse effect. And the confidence interval should not be over the 1.0. So what we see is that with the dexamethasone, there's no effect on mortality, but there is a large effect on BPD at 36 weeks. And when you calculate that, so how many patients do you have to treat to prevent one BPD patient, is that 13 patients have to be treated to prevent one infant with BPD. When you combine the outcome BPD and death, that's also a significant beneficial effect with a number needed to treat of 50. And of course, like all steroids, you get your patient off the ventilator. But early dexamethasone has short and long-term adverse effects. You have some reversible adverse effects, hyperglycemia, hypertension, and some more serious adverse effect and GI perforation, which are both significantly more in the dexamethasone treated group. But why the reason why dexamethasone the use of dexamethasone has been reduced is because of the long-term adverse effects. When compared to placebo, dexamethasone treatment has an increased risk of major neurosensory disability with a number needed to harm of 17. So treating 17 patients with dexamethasone compared to placebo will lead to one infant with major neurosensory disability. And the same applies for cerebral palsy, with a number needed to harm of 14, and the combined outcome, death or cerebral palsy. So that's why the dexamethasone, but the world has been searching for an alternative. Placebo-controlled dexamethasone shows that when initiating in the first week of life, dexamethasone reduces death or BPD. So that's beneficial, but it has both short-term adverse effects and an increased risk of death or CP following early administration. When you look at the randomized control trials initiating therapy after the first week of life, you can the Cochrane has lumped them all together, but you can divide them into a moderately early in the second week of life, second or third week of life, or after the third week of life. So the moderately early or the delayed treatment. When you take them all together, you can see that the beneficial effect is even more than in the early initiated dexamethasone trials. Compared to the trials initiated in the first week of life, remember there was a number needed to treat of 13 and 14. Here you have a number needed to treat of 7 and 6. So you only have to treat 7 patients to prevent 1 BPD infant. And when you divide them in trials in the second week of life, second or third week of life, and after the third week of life, you can see that the numbers are even more. So the message here I'm trying to tell you is that when you consider administering dexamethasone, do not postpone your therapy too long. The moderately early trials show that the BPD reduction is with a number needed to treat of 4.6. And when you wait too long, the number needed to treat goes up. So then you have to treat more infants to reduce your chance of BPD. Do not postpone your dexamethasone therapy too long. How about then the adverse effects? Because that's the reason why we're postponing our therapy. Well, in the moderately early trials, you do not have any significant effects on adverse outcomes. However, there are only a small number of trials with a sufficient follow-up in this part. But again, there's no evidence that there's an increased risk of neurodevelopmental impairment when using dexamethasone in the second week of life. When you look at the delayed, then it's also not significant, but the effect estimates are on the other side of the 1.0. Thus, there might be an increased risk, although again, there are a limited number of infants with sufficient follow-up. So in summary, the early initiation of dexamethasone shows a worrying sign of adverse neurodevelopmental outcome, and the moderately early and the delayed are not sufficiently investigated. So we are very cautious about using dexamethasone, and that's also what the AAP statement is suggesting. They state that in 2010 is that on the basis of limited short-term benefits, absence of long-term benefits, and a number of serious short and long-term complications, routine use of dexamethasone for the prevention and treatment of BPD in infants with a very low birth weight is not recommended. It should be restricted and independent of timing, and if used late after the third week of life, and a low dose of treatment was suggested. And the late timing, so too late, may not be optimal. However, even though they suggest that you should use a low dose of dexamethasone, the efficacy of the low dose has not been proven. What is the community doing after this AAP statement? That's here what you can see. So in the past century, we're using dexamethasone in a great deal of our patients, up to 80% around the millennium. And after the first long-term outcome trials were published, it sharply declined. And in the first decade of this century, we're using less than 20% steroids in our very low birth weight infants. But it is gaining popularity again without knowing exactly which dose, which drug, or especially which indication we have to use. And does this affect our BPD rate? Yeah, it might be. This is an interesting study from an American cohort published in 2009, where they investigated the decline of dexamethasone in 3 time periods and their BPD rate. And as you can see, and they divided it in the infants in the gestational age, is that in every gestational age, in the 3 time episodes, you saw a decline in dexamethasone. That's the gray bar. In every gestational age, there's when you look at, for example, in the 24-week, it went from 80% to approximately 40%. But as a consequence, the BPD rate increased from 60 to 80%. And that's the same in every gestational age cohort. How about the steroid use in Europe? There's one survey publication of 2007 showing that we're indeed postponing our therapy, and especially after the 3rd week of life. So we're doing what the AEP is telling us. But what drug we're using, that's all over the place. There are centers in Europe that are using dexamethasone, like Italia, or hydrocortisone, and it's in the same country, or even betamethasone, which has not been investigated in preterm infants in a randomized controlled setting. So this is a sign that neonatologists are not knowing what to do anymore. And there's another important movement in neonatology, and that's moving away from invasive ventilation. All steroid trials have been performed in mechanically ventilated infants. However, when you look at this cohort study from America, is that 35% of the steroids have been initiated in infants not being on invasive support. And another important figure from an American cohort study is showing that there's a large difference between centers using steroids or not. It goes from 0 to 100%. So we're in doubt. We do not know what to do. So, and when we're in doubt, we perform randomized controlled trials. And since 2016, 3 large randomized controlled trials have been conducted. Why then hydrocortisone? Well, because hydrocortisone has a different receptor activity than dexamethasone. Dexamethasone has only a glucocorticoid receptor activity, and hydrocortisone has a 1-to-1 receptor activity of mineralocorticoids or glucocorticoids. And animal data have suggested that hydrocortisone has less adverse effects on the brain. And the same cohorts in patients have suggested that it also improves the lung function with less adverse effects. However, the number of studies conducted before 2016 were limited and were only initiated before in the 1st week of life, showing no effect on death or BPD or its components. And there were some concerns about adverse effects of gastrointestinal perforation. Like I said, since 2016, 3 large trials have been conducted and partially published, and those I'm going to present now. First, the Premiloc trial in France. It's a large trial which have initiated the therapy directly after birth and in a low dose of hydrocortisone during the first 10 days of life. Then the STOP-BPD trial, which had been conducted in the Netherlands and Belgium, which used a large dose of hydrocortisone in the second week of life. And now finally, the large American trial, also using a low dose of hydrocortisone, but then after the second week of life. So these two trials reflect a nice overview of what the effect of hydrocortisone could be from birth to 20 days, first 20 days of life. So first, the Premiloc trial. Like I said, it's a large trial in France. 21 level 3 NICUs performed this study, and they included infants between 24 weeks and 28 weeks. They were enrolled within 24 hours after birth, and there were no inclusion criteria for respiratory support. So every child below 28 weeks was eligible for this trial. They investigated a low dose of hydrocortisone, and open label was not permitted during the study days. So after the first 10 days of life, open label was allowed, but not during the first 10 days. And BPD was defined as a respiratory support at 36 weeks. So not the classical Bancalari definition, but only the respiratory support at 36 weeks. They screened over 1,000 infants, and they were 10% was not eligible. Of the less than 1,000 patients left, almost half was not approached or did not consent for this trial, which left a 523 patients to be randomized. And of those patients, 2 withdrew consent. And this is the main patient characteristics of the trial. The median age was 26 weeks, with a number of 26 below 26 weeks, about 1/3. The birth weight of the infants was approximately 860 grams, and 80%, which is a large number, was intubated at randomization. There's no information on what the respiratory support or FI2 at randomization was in these infants, because that was not a inclusion criteria. What did this trial show is that there was a significant reduction in the composite outcome, death or BPD, with a number needed to treat of 12. So 12 infants had to be treated to prevent one infant the outcome death or BPD. The separate components were not significantly reduced, but both showed a trend towards a beneficial effect using hydrocortisone. Long-term outcome did not show any increased adverse effects of using hydrocortisone. So there's no adverse effects shown in this trial. So the conclusion of this trial is that there's a significant reduction in composite outcome, however, not in these separate components, and that there was a particularly low BPD risk in the survivors in placebo group, 33%, which might be important to remember when I discuss the other trials. There was a high rescue therapy after the study medication. About 1/3 of the infants was treated after the initial 10 days of study medication. It was prematurely stopped due to lack of financial support, which might be a methodological flaw, but most importantly is, are these the patients that we have in our NICU? Do they have the same baseline risk for BPD risk? And to show you, this is the a graph of the Premiloc babies, the percentage of Premiloc babies not intubated, and I compared it to a cohort in which we have been treating in the AMC. And there's a large difference. The blue bars are the Premilog infants, and you can see here the percentage of patients not intubated from day 1 to day 10. And as you can see, approximately 50% of these infants have been intubated during the first week. However, when you look at the AMC population, and it was before we were using LISA, is that in the first day, approximately 50% were not intubated, but that increased rapidly, and only 10% of the infants was intubated every day during the first week of life. So when we moved towards a non-invasive respiratory strategy. So the patients are completely different than the Premilog study population. And after introducing LISA, we also saw the first days a sharp decline of the percentage intubation in the first 3 days of life. We started at 35% before we used LISA, and it declined in the last couple of years below 10%. So even the first day of life, the bar was is going up from 50% to approximately 90%. And with this different respiratory strategy, there has to be a different baseline risk for developing BPD. When you look at other publications about this topic, there's one important individual patient data analysis performed by the original hydrocortisone trialist itself, published in 2019, where you can see again that there in the composite outcome, death of BPD, or it's the reversed outcome, survival-free BPD at 36 weeks. You see a reduced risk in favor of the use of hydrocortisone. However, again, the number of days in ventilation in this population is 32 days, and that's much more than we're doing currently in the Netherlands. And again, an open label steroids in this trials is 40%, which has been almost a half of the population is has an open label course. But more importantly is that when you look at the subgroup analysis of this IPD, you see that the smallest infants do not benefit from the use of hydrocortisone. In the subgroup with a gestational age of less than 26 weeks, you do not see a significant benefit of hydrocortisone. The only benefit you see is in the larger infants. And the larger infants have a lower baseline risk of BPD. So this is why we conclude not to use hydrocortisone in the first week of life, because you have a choice when you start treating these infants. Either you ventilate them, then you might have to use hydrocortisone, or you do not ventilate them, and then you do not have to use hydrocortisone. What is also interesting is that there might be an indication for using hydrocortisone in the first week of life, but then we have to look at chorioamnionitis, because when you have chorioamnionitis, there might be a place for corticosteroids. Then the Stop BPD trial, performed in the Netherlands and Belgium in 16 level 3 NICUs. Again, we used the same inclusion criteria, but the infants were enrolled between 7 and 14 days after birth. And these infants had to be intubated again with a respiratory index of 2.5, because we didn't want to include infants not at risk for BPD. We used a high dose of hydrocortisone, because that was currently used in one of the NICUs in the Netherlands, in Utrecht. And open label was allowed, but under strict conditions. And we used the outcome BPD at 36 weeks, defined as moderate and severe according to the Bancalari definition. We screened about more than 7,000 infants. And of those infants, 90%, over 90% was not eligible because they were not on mechanical ventilation or they had died in the first week of life. Of the remaining 500 and approximately 550 eligible infants, 31%, 32% did not consent to this trial, leaving 372 infants randomized and 1 withdrew consent. As you can see, and compared to the Premilog trial, these infants were slightly younger, and more infants below 26 weeks were included in this trial. The intubation, of course, because it is an inclusion criteria, was 100% in both arms, and the FA2 at randomization was about 35%. Here are the results of the STOP BPD trial. The composite outcome, death of BPD, was not different between the two groups. However, unexpectedly, the mortality at 36 weeks was significantly reduced in the hydrocortisone group, with a number needed to treat of 12. And the BPD, of course, because the composite outcome was not different, the BPD rate in both groups was exactly the same. And the long-term outcome was fortunately not different. So there's no adverse effect of using hydrocortisone in the second week of life at a high dose. Cerebral palsy was exactly the same between the group compared to the group, both groups, and also the composite outcome, death or CP. The unexpected beneficial effect of hydrocortisone on mortality was, like I said, unexpectedly, and was only shown after the first week of life, or after the first week of drug medication. So the first 7 days, the Kaplan-Meier curve was exactly the same, and then gradually the placebo went up and the hydrocortisone flattened. So, and that was, although not significantly in the log rank analysis, it was significantly at 36 weeks. The conclusion of this trial was that there is no significant reduction in the composite outcome. So there's no reduction in the incidence of BPD when using hydrocortisone. But the component death at 36 weeks is something we might have to look into. You can't conclude that this is a that we have to use hydrocortisone in the second week of life, because for this trial it was not powered for this outcome. It was a component of the primary outcome and not a primary outcome itself. We also have to bear in mind that although we in the inclusion criteria we had a risk assessment of BPD, it was not validated. Respiratory index of 2.5 was merely to exclude infants on the ventilator because of apnea, with no supplemental oxygen needed. But it is not a prediction model for having BPD. And to compare it to the Premilog trial, these infants were at higher risk. When you look at the survivors in the placebo group, they had about 50% BPD risk. Again, in this trial, there's also a high percentage of rescue therapy. About 60% in the placebo group was treated with hydrocortisone according to protocol. What do we see on the short-term outcomes is that there's that hydrocortisone reduces the proportion of infants failing to extubate. And we also see that in our ventilatory settings. Both the mean airway pressure during the course of the hydrocortisone and the FI2 differs between the placebo and the hydrocortisone infants. Finally, the trial of the Americans has been completed recently. This is a trial initiating therapy after the second week of life and starting a low dose of hydrocortisone. It has been conducted in the NSCSD network, and the inclusion criteria is that the infants had to be with a gestational age less than 30 weeks and enrolled between day 14 and then 28 if intubated. Again, it is a mechanically ventilated trial. And the rest of the information is scarce because it has not been published yet. The only thing that we know is that 800 infants have been randomized and that we are awaiting publication. There is one conference abstract where it has been shown that there's no significant effect in the composite outcome, which is the both the composite outcome death of BPD, no significant difference, but also the long-term outcome is also available, and there's also no difference. So we have to wait a little while before we can assess the true nature of this trial. When you compare the trials, you can see that the percentage of eligible infants in the Prevlog is about 90%, and in Stop BPD 8%. Why am I showing this? Because it might be that the Premilog, without any inclusion criteria regarding BPD risk, was not targeted enough. Again, the Stop BPD trial and also the NHCSD trial might be too targeted, and then we're too late. Maybe we have to look for the group of infants in between. Well, you can see that the Premilog and the Stop BPD differed in gestational age, number of infants included below 26 weeks, and of course all the other features. What do we know from hydrocortisone in the first week of life? Like I said, that's that there is a reduced risk of the composite outcome death of BPD with a nominated to treat of 19 when you combine all hydrocortisone trials in this first week of life, but that separate outcomes are not different. When you combine the trials after the first week of life, then you also see no difference in the composite outcome, but there might be a trend towards an effect in mortality at 36 weeks. What is the conclusion of hydrocortisone for BPD? Well, is that it definitely improves short-term respiratory outcomes. We all see that when you use hydrocortisone, that you can decrease your amount of FR2 and your ventilator settings. But there's no evidence that hydrocortisone reduces BPD. Early hydrocortisone reduces risk of death of BPD, and if you have a high BPD incidence in your unit, you might consider it. But you also might consider if you are too aggressive in ventilating your patients and should go to more non-invasive support. Late hydrocortisone does not reduce the risk of death of BPD. The BPD component is no difference, and there might be a signal towards a significant reduction in death when using hydrocortisone in this group. And fortunately, the long-term neurodevelopmental outcomes showed no difference, but also not a beneficial effect of using hydrocortisone. We have to wonder if we are aiming for the right outcome. Do steroids reduce BPD, or are they reducing mortality? When you look at the mortality and you have a reduced risk of that outcome, those infants with the highest risk remain alive and the highest risk of BPD. So it might be that all over the steroids, mortality is being reduced and not BPD. Do we need a randomized controlled trial powered for that outcome for mortality? I wonder if we're going to manage the recruitment we need for that trial. Also, we have to wonder, are we aiming for the right population? Because today there's no randomized controlled trial including non-ventilated infants. And since we're moving towards more and more non-invasive support in these tiny babies, we have to wonder if we have to perform a trial including non-ventilated infants. And are there early markers for the use of hydrocortisone? Is chorioamnionitis something we have to look for, and then as an indication for starting early hydrocortisone? But what we really need is an urgent need for prediction models. Those prediction models we have been looking into is why do we need them? Because we are moving towards a non-invasive respiratory support. Those prediction models should be built from widely available parameters, bedside parameters we can use. It should not be on a complicated calculation of lab test. And those prediction models, and that's an important message from me, is that we should be conducting them in a proper way. And I'll show you in a minute. Of course, they have to be of high discriminating power and good calibration, and especially the last part, the good calibration, has not been done in many prediction models for BPD. When I'm talking about 5 stadia of prediction, first you have to develop it, but then an internal and especially external validation is not commonly performed, let alone that we are doing an impact analysis. So when you use a BPD prediction, what's the impact of using such a prediction model? And after that, we have to implement it in the daily practice. We have been looking in the BPD prediction studies in 2013, and we're going to update a new systematic review soon. And what we have seen is that there are many BPD prediction models, but none have been used in daily practice, because there's a lack of, definitely lack of external validation and a lack of calibration. What you can see is that there's a high risk in these models for risk of bias, especially in the analysis part of the prediction models, because they are not reporting missing values and how they handled it. But especially the model validation in the external validation or the calibration has not been used in many prediction models. First, we have to do that part of our research. You can see the area on the curves of the external validation studies that have been performed to date, which definitely have to be improved, because a C statistics below 1.8 is not sufficient enough to be used in daily practice. And this is why we have to do a calibration plot, because we've been doing that on an external validation study. We have been performed where there's a sufficient area on the curve, but the calibration plot, as you can see, is way offline. What a calibration plot shows is the predicted probabilities and against the observed probabilities. And what it should do, it should follow the 0.5 line. But instead of that, the calibration plot is way below. So it's definitely under fitting in this model. Like I said, poor calibration and efforts discrimination for BPD. There are a lot of biomarkers out there suggesting it is of a prognostic value for BPD, but it's only in association with studies. And what we have to do is update the existing models using high resolution data or biomarkers, or even use omics. And we have been doing some, and this is really exciting news. And we have been trying to get a biomarker, and where better to get a biomarker than in your exhale breath. And the adult medicine is already using the VOC, so the volatile organic compounds, in exhale breath, and they can detect pneumonia, RDS, asthma, COPD, or even therapy-resistant asthma. And since BPD is a inflammatory or partly inflammatory disease, you might find in your exhale breath inflammatory markers. What you do is you capture the exhale breath and make exhale breath profiles using GCMS. You get distinct breath profiles of BPD infants versus no BPD infants. This is the very first results we're going to present soon, where we have looked into 120 BPD infants, 120 preterm infants, with 30% had BPD. And here you can see that the breath prints are show a distinct pattern. And when you go for a prognostic model, you have an area on the curve which has been really exciting, a high area on the curve. Again, we have to internally validate, externally validate, and then do an impact analysis. But it's a first start showing that in exhale breath, you can find a prediction model for BPD. So where do we start from here? Well, first, we have to put some effort into an external validation for BPD prediction model. Clinical, but also including biomarkers. We have to decide which population are we targeting. Are we only sticking to the mechanical ventilated infants, or are we also going to include non-invasive supported infants? But then we have to decide what is the timing of the drug, what dose, and which drug do we use. And finally, is there a need for a DEXA versus hydrocortisone trial? That's my last slide. Thank you for your attention, and I'm happy to answer any questions.
Thanks, Wes. That was a great overview with particularly all the modern trials and up-to-date trials with a summary of what happened before. And I think you highlighted a couple of really important parts, which, me from my hemodynamic background, sounds very familiar to what you found in the PDA trials. It's about selection of patients. How do you do that? And you brought us some really interesting new ways of looking at that. Timing of treatment, which comes across everywhere, and in a trial, we open label treatment as a major concomitant factor in why you can't interpret the trials, because a lot of babies in the placebo group got the treatment anyways. Now, there's a couple of questions in the chat. Brad Manley from Melbourne was in there. I think he's off with his kids now. So, but he had two questions, which I think is interesting. Out of these factors, and you already used your last slide, if we want to do a collaborative trial, like worldwide trial, and we have to look at this timing, indications, and drug doses. You think we can do that all in once, or if you have to pick one, which sequence, which one do you think is the most important? Timing of treatment, indications to select patients, or the drug and the dose?
They're all very important, Kurt. Thanks for the question. But I realized yesterday that what we're doing wrong for all those times is we're not putting enough effort into the indication, selecting the right population at risk. We are focusing on treating them as they're all one and the same patient, but they're all different with their own patient characteristics. So if I had to choose, I would choose first select the right population with the right patient characteristics.
Yeah, no,
and then move. And if you are definitely sure that there's a high risk of the outcome, then move towards can we use individualized dosing, and then finally which drug and timing, etc. But it starts with it starts with indication.
Yeah, look, it would be my personal choice as well, knowing which patient to treat. Let's go a little bit in that. In your studies where you reviewed BPD prediction models, I think even you went into predicting mild and moderate versus severe and the selection. I think the only factor which was very clear came out of it was gestational age. So what do you think, if a baby is 23 and 24 weeks and they have a very high risk of getting significant BPD, should they not all get steroids then?
No, because why are they all getting BPD? If it's for inflammation, yes, they then steroids might be a proper. But if it's not for inflammation, leave the steroid side, because it hampers your lung development one way or the other. It hampers the inflammation. That's why we're using it, but it also decreases your lung development. So if you're not having any inflammation, why should you use a medication which stops your lung growth? Yeah. So again, also in the 23, 24 weekers, we are not treating 23 weekers in the Netherlands, but I would suggest also look in that population for inflammation or not inflammation. So it's a balance, inflammation versus lung growth.
How do you do that?
By putting some effort in the exhale breath.
That's an idea. There's a question here from Atul Malhotra, and that's a good one. Can you talk us through the rationale of all these dosing in different studies? Why is there such a difference in dosing of hydrocortisone?
I'm not sure. The difference between the Premilock and the Stop BPD trial is pragmatic. The Stop BPD trial used a high dose because that was the dose used in Utrecht, one of the NICU's in the Netherlands. They have never used dexamethasone. So since the 1970s, they've been using hydrocortisone in this dose. If you ask the original dexamethasone trialist, why did James Cumming use a tremendously high dose of 8 milligrams per kilogram? They're going to do, well, we did like this. And the same happened.
Pharmacokinetic data?
No, not at all. The only thing we know is that we're using supraphysiological doses of cortisol derivations.
Yeah, right. All right. So Brett had another question, which I really liked. You know, why is there? And you showed actually some of the data that we've been now trending towards using it later, which is actually not really effective. So why is there such a reluctance for us to start it, say, on day 8 instead of day 14? Because you showed the short-term benefits of lower FiO2, lower mean airway pressure, higher rate of extubation. Why do you think there is such a reluctance?
Because because of the fear of the long-term outcomes, and in the moderately early trials, there's not enough patients enrolled or follow-ups to show that there's no harm. We're all extrapolating the early initiated trials and the adverse effects on the neurodevelopmental outcome to the secondary life, but that's a totally different population, where you have a more targeted high risk of adverse outcome infants in the second week of life. In the first week of life, you don't know which way the child is going, towards a uncomplicated course or very complicated. You need the first days, because we don't have any real nice clinical prediction model or biomarkers to put you in a high risk or a low risk of BPD in the first week of life. So that's why we're postponing our therapy to wait and see, maybe he doesn't need it, maybe he doesn't need it. But then you're too late, and the reversible lung damage goes to irreversible.
I can understand there will be intermittent and intercurrent things, late onset sepsis, persistent PDA are two of those things. When you're using the breath, the BPD breath test, at what day do you use that?
Well, now it's in research setting. So what we're doing is we're doing it at day 3, day 7, and day 14, just to see if there's a decline, to see which marker we're going to look for.
And as you explained, the inflammation comes from different causes. One is indeed lung development or lung inflammation. Another might be pulmonary volume overload from a PDA. You see differences in that breath analysis on those two things? Yes or no PDA?
Yeah, well, unfortunately, Kurt, for you, the groups are too small. So what we're now doing is, because this test has been developed in the AMC, we're going to do it now in a multi-center in the Netherlands, and maybe we can tease out what the role of the PDA is. But now the groups are too small to say anything about that.
Okay.
Or for that matter, bijvoorbeeld, for example, small for gestational age. Yeah. Because that's a completely different group of infants also getting BPD without inflammation. And to come back to what we said before is, if you have a small for gestational age and you're treating without inflammation and you're treating it with corticosteroids, it's not only antenatal and deprived lung development, but also postnatal, you're doing it again.
Yeah. Because there's a question in the chat from Dr. Kasuda about the associations with inflammation, which, as you said, growth restriction is one, PDA can be one, late onset sepsis can be one. And he asked if there is, in a subgroup analysis, did you see more effect on CAM? So CAM, Dr. Kasuda, what do you mean with a CAM? CAM.
It's chorioamnionitis.
Chorioamnionitis, yes. So is chorioamnionitis one of those factors? It comes out of all the trials.
And now you're referring to the Stop BPD trial.
Well,
yes.
Yeah. Yes. No, we didn't see that one in the Stop BPD trial. And that might be that because it's in the Stop BPD trial, it's a very selective population. Like I said, it's from 1,000 infants potentially. We only included 9% of the actual population. I think that with the Stop BPD, we targeted it too narrow. We have to look for a broader, maybe we can include less severe infants with chorioamnionitis in the second week of life, on ventilation or not ventilation, but only in a randomized controlled trial. I'm not suggesting to use it in daily practice. We have to think about a trial with a proper inclusion, etc., etc.
All right, so I guess the respiratory teams amongst us still have a large journey to go to make the trial which can answer these questions. And as you mentioned, I think it's not going to be one trial, it's going to be still several trials to try find out a couple of these items, which for some of them we won't find an easy answer as well. It's 6 o'clock. I don't see any new questions in there. And thank you, Wes, so much for spending your time and explaining for us. Thanks so much for presenting.
You're welcome.
Hope to see you in the Netherlands soon.
Same here. Bye, Kurt.
Bye-bye, Wes. Thanks, everybody, for your attendance. And thanks, Wes Onland. He's a colleague of mine. We both trained in the academic center in Amsterdam, in the Netherlands. And Wes just told me it was 2008. I thought it was earlier, but I remember it as being earlier, maybe 2005. So we both hang around in the NICU and did a couple of projects together and particularly worked a lot together. And Wes has gone from just his interest of working particularly on ventilation, which was a high topic in the academic medical center, to, now did his own trial looking at hydrocortisone in preventing BPD and other BPD and dexamethasone related work, particularly in overviews and systematic reviews of these trials. So Wes, we're really glad to have you here. The floor is yours.
Thank you very much, Koert, for this kind introduction. Let me share my screen again. There we are. All right. Well, thank you very much for the invitation. First of all, I would like to thank the organizing committee. But I wanted to start that I have no financial relationship, but I am the co-PI of the one of the trials I'm going to present. So bear that in mind. First, I wanted to show that where do I come from? Well, from the other side of the world. And I had to draw a big arrow to show you where the tiny dot is. That's the Netherlands. That's where I live and work and where Koert is coming from. So, and the Netherlands, I don't know if you ever heard of it because it's so small, but what we are doing in the Netherlands is constantly fighting against water. We have a lot of water. It's below the sea level. So what we're doing is building. If we do not build any dikes, then this is what the Netherlands would look like. Approximately 20% of our country would be left if we do not have any dikes. What do you know the Netherlands from? Well, I think from the windmills, from the ice skating, especially now in the Olympics. The Dutch are very good in skating. But what we know from the Netherlands is it's flat. We do not have any hills. That's something all tourists are surprised about, that it's completely flat. And this is where I live and work, and that's Amsterdam, the capital of the Netherlands. What about the NICUs in the Netherlands? Well, we had 10 NICUs. We have approximately 165 births per year. And in those 10 NICUs, we admit about 1,000 infants below 30 weeks. Recently, we have become 9 NICUs, because in the Amsterdam, there were originally 2 NICUs, but we have merged, and now there's one big NICU in Amsterdam. That's a complicated process, I can tell you. This is what the AIMS looks like about 50 years ago, with a lot of cows before it. That's the AMC. And my personal history is that I began my residency in the NICU in 2002. And at that time, the neonatologist, among which Koert was wondering, what should we do with dexamethasone? Should we lower the dose? And since then, like Koert said, I got definitely interested in the steroid use in neonatology, wrote a couple of systematic reviews, and was the co-PI to stop BPD trial. But it all started, and that's what I pointed out, in 2005 with this publication, one of my first publications with Koert. So it's like circle of life. We're back at the beginning. For the next 40-45 minutes, I'm going to tell you about steroids and focus on the randomized control trials that have been conducted for the past 5 years. First, a few words about why do we use steroids? What is the evidence from the randomized control trials before 2016? Because we have been investigating dexamethasone and hydrocortisone for quite some time now. What do the guidelines say to us, and what are the consequences of those statements of the guidelines? And then finally, the focus on hydrocortisone trials which have been conducted and published after 2016, and then conclusion and future perspective. So first, why do we use steroids? Well, because BPD, we want to prevent BPD. It's a very common complication of preterm birth, and it has both neurodevelopmental and pulmonary long-time, life-lasting consequences. And this is a picture showing that BPD is a complicated,